Some are called foundation models. And we, in my own lab, have been writing about this extensively and designing our own large language models. One of them, for example, recently talked about is called Love It, generated by one of the students in my own lab. The lab in question is called the London Institute for Healthcare Engineering. It is based at St. Thomas's Hospital. You can see the view from the roof. You can see the Houses of Parliament, and they can see us. So we are very prominently placed. And we have today the fastest MRI, every possible sensor, and more about sensors in a minute. Most sensors that are available to record what our patients do, computational modeling, smart imaging probes, and most importantly, affordable technology. We actually have Prashant Jha as a professor of frugal innovation from the All India Institute, who now lives with us in the London Institute for Healthcare Engineering. So I'll cover most of the urological cancers and where we are today, but this is a paper published last year on AI in prostate cancer, and I will come up with real life examples of what is happening in this space this year. So this is one such example. We have designed something called autoprostate, where the algo can actually segment the prostate and the significant cancer within it and be an adjunct to a radiologist's report, because it takes away that toxicity, so to say, of differences in reports amongst human beings. We are not trying to replace our radiologists. We are just trying to augment what they do. The commonest and the most recognized article in this field of recognizing the pathology and predicting the Gleason grade group is called the PANDA Challenge. This was published in Nature Medicine and in over 10,000 slides available on a platform called the Kaggle platform. Programmers from all over the world were invited to see if their algos could outperform human beings. And they did that in 75% of cases. So again, we are not trying to replace our pathologists. We are just trying to augment what they do. Today, NVIDIA is based at the London Institute for Healthcare Engineering, and they have given us something called Mona AI Label. Mona AI Label is very, very interesting, because what it can do is take a 2D image, segment this, which used to be done manually, in a semi-automated or almost automated fashion, because we have been training it over the last 3 years to generate a 3D image like you see on the screen. And then you can print a button and get a 3D print, take this image into the operating room. So you can personalize the operation for the patient. Here is an example where in T3 prostate cancer, you can see on the right side, the tumor anteriorly is literally a millimeter from the sphincter. You can reduce in these patients the positive margins from 35 to 10% and preserve their continence and sexual function even better. The trial on this is called the Touch and Image Guided Robotic Surgery Trial. This has just been published in the BJUI. 3 arms. You turn up, look at the MRI, and operate on a patient with a robotic system, whichever that may be. You use Mona AI Label to generate a 3D print or 3D image. The 3D image is on a computer screen, which you can fly in to the operative field, and then you look at cancer outcomes and oncological outcomes with prompts. And clearly, this is the first such trial showing that in these patients, you can reduce toxicity and improve outcomes. Andrew Hung, currently in CDARS, has been instrumental in taking these videos and generating what is called automated performance metrics, again, trying to improve erectile function and reducing the risk of urinary continence. So the study that is currently ongoing and just published in the Hamlin Symposium is by our colleague Margherita from San Rafael, who has been working with us for a year. We have a joint program between Italy and London, and again showing that there are certain gestures using that large language model, which I described to you, called Love It, which can reduce the risk of getting positive margins in these patients. Now, this is again an important paper which we were part of called the Ideal Framework, where whenever you get a new intelligent system, whether that be an algorithm or a new robot, we have started using evaluation with a stage 1 right through to stage 4. The Da Vinci is in the stage 4 situation because this is long-term follow-up, but stage 3 is where the randomized trial happens, and before that you have 2A and 2B. Again, you see a very significant publication in this space. So this is the world's first stage 1, 2A of robotic prostatectomy and robotic partial nephrectomy with the British Vercius robot, warts and all, showing not only that it can be done, but it takes longer with a long learning curve. And this year, we have published the first ideal stage 2 study. So there's a structured program of the Medtronic robot showing that the problems that happen with the robot, for example, arm failure or complications such as urinary leakage due to anastomotic leak, happen in the first 20 cases. So beware when you are evaluating these machines early on, because there can be some problems. Now, you will know this, particularly Sudhir will know this, because we have been trying to do telesurgery, a buzzword, just hot topic currently, trying to operate within the nation, particularly in India, for example, but also across nations. And the challenge here is the delay, which you can reduce with 5G and AI. So the first such 5G procedure was done by us on Facebook Live in 2018. We had a headset, we had a virtual glove by which you can feel inside a patient without making an incision. We had 3D printed tools and we had real-time slicing with 5G. And then, of course, 2 years later during COVID, our Chinese colleagues took over. So the France to India operation has just happened 2 weeks ago using the Mantra system with a very low latency. But please remember in all this that the surgeon-patient relationship has to be the topmost. So patient safety must not be compromised just because we can do this across 10,000 kilometers. Now, what about renal cancer? One of the ways of reducing unnecessary surgery would be to detect better the patients who are likely to have benign tumors, which is 25 to 30%. And AI has really helped with novel radiomics to try and do this and reduce the need for unnecessary surgery in some of these patients. Using 3 genes, particularly FOXC2, PBRM, and BAP1, people have developed, particularly in Korea, a deep learning model to see if you can reduce the risk of recurrences of these cancers and the role of adjuvant treatment in some of these more aggressive tumors, even if they are T1. In testicular cancer, my colleague Nikhil Vasudev has been doing some excellent work in Lister, looking particularly at the risk of lymphovascular invasion in these patients using artificial intelligence. In cystoscopy, of course, particularly blue light, you cannot tell looking at these images which of these red patches are likely to be cancer. And AI achieves a much better area under the curve on predictive models if you look at using such algorithms. And there are 5 of these currently in the market of trying to predict which of these are likely to be cancers rather than just a red against blue on the blue light image. Now, you would all have heard of the IROC trial comparing open cystectomy versus robotic cystectomy with intracorporeal reconstruction. You will see at the lower end was a test that was used called the chair to stand test. We were part of this trial. This is called 30 CTS, and the patients were monitored with sensors. I mentioned sensors right at the beginning. And here on the curve on the right, you see that the recovery of patients at 5 and 12 weeks, those who were using the CTS technique, was better than those who were just turning up. In the UK, I have the great pleasure of leading something called the Responsible AI UK Health and Social Care Working Group. This is funded by the Engineering and Physical Sciences Research Council. It's an international ecosystem which is trying to put an AI champion in every hospital. So if you're working in this space, not just intrigued, but working in this space, then please get in touch with me. One of the parts of it is to try and improve the regulatory framework, particularly within the EU, where the attitude is to try and ban anything in health and social care because it's seen as a high risk. So we are in this Nature paper asking the EU to think again. Finally, something very, very topical, which is the role of automation and AI. And here you see a horrified surgeon looking at a machine which has been cloned to perform his or her movements and reduce surgical waiting lists, of which there are nearly 30 million post-COVID. The levels of automation go from 0 to 5. There is currently no 4 or 5 autonomy. 5 is full autonomy. The Da Vinci is level 1, and the Aqua Beam, the probot today, is here in number 2, and Aqua Beam is water jet ablation is in level 3. So we don't have a level 4 or 5 today. So about 10 days ago, Hopkins published this paper, which was discussed again in the Society for Robotic Surgery meeting in Strasbourg. And the idea was that in a pig model, you can completely automate a laparoscopic cholecystectomy. The week after, I was asked to chair at the Royal Academy of Engineering a patient and public-facing AI summit where there was a live artist, would you believe, drawing these diagrams of what the people who are at the receiving end were saying. And I asked them whether if 100% fully automated robot was offered to them, whether they would today be willing to have surgery with no complications. And the answer very simply is not yet. The public are willing to be part of trials, but they want a human in the loop while these automation trials are ongoing. So I leave you with that thought. Do involve the public when you get excited about a robotic tool or an AI tool, because they may not quite be willing to accept what we are. So thank you very much again for inviting me. If you have any questions, then I'm happy to take them. Goodbye.
Comment. Yeah.
Okar?
Yes, sir. I'm here.
Sudhir.
Sudhir, how are you? Good afternoon, Sudhir.
Rather morning, almost. So I missed you in SRS, and I did see that report of automation, totally, automatic, the independent gallbladder was done by this from Johns Hopkins. Do you think this will definitely happen in future in next 5 years or so?
So I think, Sudhir, we will hear more about other such tools, but the simple answer is I don't think this is ready for prime time yet. So the proof of principle is there. We have a number of automated tools ourselves, but the patients, individual patients are so different, particularly with complex procedures. A patient of African origin has a completely different pelvis, for example, to an Indian patient. And we do not have enough granular data to train these algorithms to be fully automated. And the public, who are an important part of this, are very willing to be part of trials, but they want a human in the loop. The surgeons, of course, are worried about the future of work. They are thinking, my job will be taken away. So I think this will be, the simple answer is not yet. Human trials will take place, I suspect, over the next 5 to 10 years, but it's not ready for prime time yet.
Thank you.
Thank you. Thank you, Dr. Dasgupta, and have a good day. We'll go on to the next talk. Yeah, we'll call upon Dr. Gagan Prakash. He's the head of Tata Memorial Urology Department. I know he's come a long way this morning just to give this talk, and he's going to talk about blind spots in toxicity reporting criteria for uro-oncology. I'm sure we'll talk about recording and reporting, Gagan, and expecting either also.
And talking to me coming. I think the mic is filling after the AV talk.
Mic is not a problem. Slide.
You go over something.
You have to stop this one first and then. Oh, yeah. No, already. He has opened this. Right click करो. हाँ ये ना. Yeah, close all the Indian way. Yeah. Tilt the scooter before. So as we are getting this set up, I think from a very, very modern concept and talk and technology, we would go on to something which I see as an ancient problem. I'm just trying to give a different perspective to it. And not many words and text on this presentation, probably lots of slides. The talk has been called Blind Spots in Toxicity Reporting Criteria in Urologic Oncology. This is something which me and Amitabh discussed and planned, and eventually it landed with me. And I must confess that this is the first time I'm talking on a topic like this. Greetings from all the centers of Tata Memorial Center and the MENCAN initiative, which all of you are aware of. So the inception of this talk happened through various conversations which we've had in meetings between us, the surgeons, the radiation oncologist, and the medical oncologist. Some nice and some not very nice conversations, and some behind the scene conversations as well. And some concerns like, one person telling the other that your toxicity is underreported, or, we manage long-term toxicity that you have created possibly, and you are not even aware of, or it is too early to rejoice about the low toxicity of your modality. I'm sure many of us would have been a part of or have witnessed these conversations. So just trying to see if there is something, something which is within the system because of which we are getting this perception. Some disclaimers and disclosures. The intention of this talk is provoke some thought, more of an observation-based than an evidence-based talk, but certainly an opportunity for SOGO to build up on this topic. I would try hard to forget for the next 10 minutes that I'm a surgeon or a urologist. And please consider, with due respect for all the things that I say for my worthy non-surgical oncology colleagues, bladder cystopathy following pelvic RT is something which is of area of interest, and a lot of things come from that. And I would like to thank Dr. Ramya Nagarajan and Dr. Amandeep, both of whom are senior urologists, uro-oncologists, with whose ideas I was able to complete this presentation. How is toxicity graded and reported in oncology? So amongst surgeons, radiation, and medical oncologists, these are the commonest used systems. The Clevin-Dindo system, which categorize complications from 1 to 5. However, it does not account for cumulative morbidity, or also does not account for subjective patient impact. The CTCA version 5, which is most commonly used in trials, gives a detailed framework for classifying treatment-related toxicities in oncology trials. However, not very commonly used in surgical settings. The radiation therapy oncology group, or the RTOG criteria, grades radiotherapy-associated complications from grade 0 to 5, however, lacks a cross-applicability
to surgical complications. CCI, or the Comprehensive Complication Index, which has tried to troubleshoot some of these issues, is largely underused or underutilized. And the patient-reported outcomes, or the PROMs, is something which is underintegrated and probably, picks up a lot of things which one would otherwise miss. And for this talk, these 5 complication grading toxicity or classifications I would refer to as the indices. Let's look at the first point. Toxicity grading does not capture what the patient is experiencing. So you have a certain perspective and you are capturing a few grades, but the patient could be undergoing through something else. Indices are clinician-reported, PROMs or PROs are directly from the patient. Indices focus on medical severity. The PROs capture the lived experience by the patient. Indices often used alone in trial, and PROs should be included. And there are various examples of these PROs that we are aware of. Now, whenever there has been an attempt to relate or correlate what the patient has perceived and what was the physician-reported outcome, most of the studies have found that there have been discrepancy, and some of them have actually reported huge discrepancies where they found that the physicians have underreported what the problem was actually. And such things comes from surgical trials, it comes from chemotherapy-related papers, where the concordance, this I picked up because this is one of the most recent ones, concordance between the patient-reported outcomes and the CTCAE clinician-reported toxicities, there are discrepancies or discordances. Now, one of the things which comes to help over here is the concept of pro-CTCAE. So you use the CTCA and then add the patient-reported outcomes to it and make an integrated pro-CTCA. And so much so that the NCI has now an online support system where one could use this to create your own PRO along that can be integrated with the CTCAs. So you have a list of complications or things that you would think is relevant to the area or the surgery that you are considering, and then you can build up your own pro-CTCA. But the bottom line is that the more of pro-CTCA you use, the more likely you're going to capture the actual picture. The next thing, and probably the most important, the most controversial of it, would be about the granularity of reporting toxicity. I want you to have a look at this bladder diary, which belongs to an elderly gentleman who had a TURP and a hypofractionated radiation therapy 2 years back. Now, this is the bladder diary. You can see that he's voiding anything between 150 to 200 cc's an hour, or probably just over an hour. There have been some breaks while he's having his breakfast or while he was in the middle of his meeting in the office. And any guesses what was this toxicity reported as? 1 or 2, yeah, at the most. Okay, so let's look at these things more in detail. So when you talk about urinary frequency, the CTCAE, the maximum toxicity is grade 2. You don't have anything beyond grade 3, 4, 5. So if somebody is going every 30 minutes for the rest of his life, is also captured as grade 2. And with the RTOG, particularly the late toxicity. For example, in this patient, this was 2 years later. So we are talking about a late toxicity post-radiation. The grade 2 toxicity is moderate frequency. What is moderate frequency is left up to the investigator or the clinician. Somebody has tried to put on some numbers to this. And when you try to make them more granular, the grade 2 toxicity, which we thought is moderate, has been called as frequency during the day 1 to 2 hourly. Nocturia 4 to 6 times per night, moderate dyspneuria, we don't know how to say what moderate is, hematuria requiring medications, and a bladder capacity which is 150 cc's. So somebody who's been getting up 4 times at night, has a 150 cc capacity's bladder, would also be called a grade 2 toxicity. Now, I'm not saying that things are very well sorted in the Cleveland endo on the surgical side, but there have been some attempts. So, for example, let's take this tailored classification, which has been done for neobladder and has been included in the EAU guidelines. But what they've done is that every possible thing which the patient is likely to have post a neobladder, that morbidity, along with the likely management, has been put in the various grades. So we have a little more granularity than just saying that moderate frequency or moderate hematuria, things like that. So there's a grade 2 toxicity, things what have been done, and similarly a grade 3, 3A, 3B. in the clavin endo. And there have been attempts to do this across oncology, not just urology, but GI surgeries and breast surgeries where the clavin endo has been tailored for that particular surgery based on the scenario. Let's go to the next issue, the issue of cumulative toxicity. So when we talk about cumulative toxicity, there are two things. One is time-bound thing. So somebody who's had hematuria in the first few years, and then an added dysuria, and then an added frequency, or maybe the other way around, and then an erectile dysfunction or things. Over the years, these are often not captured. You might just take one thing at a snapshot, and these are reported. Also, the cumulative toxicity in terms of various toxicities of various grades. So there could be one toxicity of a higher grade, the other one of a lesser grade, and they're also not captured well. There have been some attempt from our center, our radiation oncology colleague Supriya led this trial, where they've suggested MOSES, which is months and severity score, which what it does, it calculates a cumulative toxicity over the years, and they've clearly shown that this is a far better way of reporting. The CCI has also tried to do this, have a more cumulative version of the toxicity. Let me try and explain these things with some stories. We understand stories better. So scenario 1, CTCA underestimates functional impact. 70-year-old lady who has had brachytherapy for cervical cancer 7 years back, has been disease-free, free of cancer, has hemorrhagic cystitis, has gross hematuria 1 to 2 episodes every week for months together, requires transfusion every few months, has undergone 38 cycles of hyperbaric oxygen because 40 is close to recommended, multiple visits to the hospital, and obviously financial toxicity along with it, has been captured as grade 2 late toxicity on the charts. Scenario 2, indices ignore cumulative toxicity. Elderly male, diabetic, multiple TURBTs, BCG, progressed to muscle invasive disease, bladder preservation was done, chemotherapy, radiation therapy. 2 years later, he gets into the Chakravyuh. I don't know what's the better word for Chakravyuh of hydronephrosis, stent, UTI, hematuria, stent change, the cost associated with multiple visits, the anxiety related with various visits has been again captured possibly as a grade 2 or maybe at some occasion as a grade 3 toxicity. Scenario 3, the grading does not correspond to the resource intensity. Elderly male treated with androgen deprivation and RT, locally advanced prostate cancer, has grade 2 proctitis as per the charts, but essentially is requiring repeated enemas, repeated visits to the casualty, maybe some colonoscopies and prolonged therapies. And the amount of funds that he's draining for these toxicities, I think we have a talk on financial toxicity as well. Scenario 4, this is more for surgeons. Acceptability of complications could be related, or we try to relate it to the surgical intensity. Scenario 1, amongst this, so there's one patient who's had an RPLND for this, difficult retropleural tumor. You can see this is 360 degrees encasing the aorta, largish mass. And there's another patient who's had an high inguinal ochirectomy. Both these patients have complications in the post-operative period. One requires a pigtail for the chyle, and the other one requires a secondary suturing. Both these toxicities would be the same. But in the surgeon's mind, do you think they're the same? Which one would be you have the more acceptability for? Just a pigtail placement after a huge supramajor RPLND, or a secondary suturing after an ochirectomy? And there have been some suggestions to tackle this as well. Scenario 5, no grade for psychosocial toxicity. Post-radical prostatectomy, a patient who was very active in his senior citizens club continues to use diapers. He, as per the charts, has a grade 1 continence because there are occasional pads, but the impact on his psychosocial scenarios, the shame, the depression, the cost, and also the diaper-related issues is something which often doesn't get captured. A little more, just one possible slide talking about something from the papers, a landmark result in the context of these blind spots. So this is outcomes of a hyperfractionated SBRT for intermediate high-risk prostate cancer, comes from one of the most reputed groups, and has reported in the conclusion that SBRT is a viable option to deliver the boost dose, achieving promising biochemical control and reduce PSA-Nadir with minimal toxicity without a surgical procedure. A closer look at this minimal toxicity tells us that the late GU toxicities were 25% in these patients. And if you try and look at what the CTCA, this grade 2 means, things like urinary fistula, if the patient has been on a fistula and a catheter for the rest of his life, is also captured as a grade 2 complication. A patient, yeah, so the same thing with frequency, it doesn't go beyond grade 2. And urinary retention, somebody who's got a SPC or a catheter and a self-catheterization for the rest of his life is also grade 2. My last slide, rethink toxicity. Ask patients what are they experience, not just what the toxicity grade shows. So include the PROs. Recognize functional and emotional impact of low-grade adverse events. Don't think that they are low-grade. They could be meaning something else for the patients. Pick the cumulative burden, make an attempt for that, and design trials with quality of life and symptoms burden as endpoints. Thank you. Thank you. A very smart move by a radiation oncologist. No, I'm just kidding. Yeah.
So, subjective or?
Yes. Yeah.
Let's say that.
We're fine. Look, Shankar Prinja is a
financial toxicity.
sir.
Sir.
Thanks.
Doctor, you have to unmute yourself and can you share the.
Yeah, sure, I can do that. I wasn't able to hear that I need to start, so I was just waiting for you to say so. I'll do that. So if you can just confirm to me if you can see my slides in full view. I think I just need a confirmation if you can see my slides in full view.
Can see your slides, sir.
Okay, thank you so much. So, thank you very much for your invitation, and my apologies I could not be there in person. So, I'm glad that you've introduced this particular topic on financial toxicity related to the genitourinary cancers, and I'll try and share my thoughts on this particular topic over the next 10 minutes by giving you a bit of an overview on what is the burden of the problem, and then what are some of the interventions, either through policy or through some of the other mechanisms that are being put in place in order to reduce this financial toxicity. So something on the solution as well. So I don't need to tell this audience that about the burden of the genitourinary cancer and the trends that are coming in. So I'd rather skip this slide. But I'll straight away come to this particular of the extent of financial toxicity due to cancer. And what we see on the right side of the graph. Sorry, yeah. What I see on the right side of this of this slide are these two graphs. So if you look at the top right graph, it basically shows you what is the average out-of-pocket expenditure that a household has to bear, either for a non-hospitalized treatment when he comes in an outpatient setting and gets a treatment, either in the form of some kind of, let's say, chemotherapy or a radiotherapy, or if he has to undergo a hospitalization, which is as a result of some kind of surgery or some kind of complication, or which of other treatment which requires a hospitalization. So these are some mean estimates. But what is more important to also understand is that it is not just a one-off episode of treatment, as was being shown in the talk by the previous speaker also, that the cancer treatment goes on for a long period of time for any particular patient. So as a result, if you look at the annual out-of-pocket expenditure, so this was the upper slide, the up top right graph basically shows per episode of treatment, whether in an OPD or an IPD setting. But what we see on the bottom right graph is the kind of annual expenditure. So if you look at the total annual expenditure per patient, it goes more than 3 lakh rupees. So it's close to about 3.5 lakh rupees is what an individual spends in an entire year once he's diagnosed of cancer. Another important interesting thing is that unlike many other disease conditions, or unlike some expectation that you feel that maybe hospitalized treatment actually leads to a greater expenditure, it's the non-hospitalized form of treatment that the patient undergoes treatment in a daycare center or a OPD setting, etc., which becomes much more repetitive. And as a result of that repetitive nature, the overall volume or the quantum of expenditure is actually much higher. And on the bottom left, the graph that you see are two indicators of financial hardship that we generally compute. The blue bar, basically, on the left side, the two bars are showing the prevalence of catastrophic health expenditure. So what we mean by catastrophic health expenditure is, so for example, a family, let's say, has an annual income of, let's say, or a monthly income of, let's say, 1 lakh rupees. Then of that 1 lakh rupees, if the family is made to spend more than, let's say, 40% of that on healthcare expenditure, we consider that as catastrophic. So anything that is beyond a certain limit, beyond which we feel that the person will face financial hardship, will have to cut corners for some of the other important sustenance expenditures, etc., that is what we call as catastrophic. And on the right side, the two bars are impoverishment. That means as a result of healthcare expenditure, what proportion of the families are actually pushed below the poverty line, which we have set, which classifies an individual to be below poverty line or above poverty line. So we see that not only is there an absolute overall high amount of expenditure that people have to bear, but the prevalence of the catastrophic expenditure, health expenditure, or impoverishment is also reasonably quite high, which means that people have to actually face a lot of financial hardship as a result of cancer treatment. And this is based out of a study that was undertaken across 7 different cancer centers across India, capturing data from more than 12,000 cancer patients of different primary sites, etc., that were recruited and who were getting treatment in these centers. But I tried also deriving similar estimates specifically for the kind of cancers that would get classified as genitourinary from within the same sample. And the results are not too different actually. Whether in terms of, if we look at in terms of the extent of the financial toxicity in terms of catastrophic expenditure or impoverishment rates that we have for different types of genitourinary cancers, the estimates are very similar to what I showed you in the previous slide for the overall all types of cancers. So having said that, there is a significant burden of this problem of financial toxicity. There are certain things that the government is also trying to put in place in order to reduce this financial burden of cancer treatment. And this comes in the form of certain interventions that are being done in order to detect the cancer cases early. But there is also something that is being done in order to overall provide some kind of financial protection of treatment once you are actually detected and you have to get yourself treated. So on the prevention side, there is an attempt towards expanding the coverage of population-based screening for 3 important cancers. So while it doesn't currently incorporate any of the genitourinary cancers, but the priority right now under the National Program for Non-Communicable Diseases is to screen the population between above 30 years of age for 2 non-communicable diseases, which are hypertension and diabetes, and 3 cancers: cervical, breast, and oral cancers. So this is the attempt at the population level to be able to screen and detect at an early stage so that you do not let them reach. So the attempt is basically is to have some kind of downstaging that is possible. But the other program that is coming through another pillar of Ayushman Bharat, which is the Pradhan Mantri Jan Arogya Yojana, is to provide financial protection against treatment of cancer in a set of more than 28,000 hospitals, both public and private sector, that are empaneled within this Pradhan Mantri Jan Arogya Yojana. So this is a completely tax-funded health insurance program which aims to cover about 40% of India's population as per the socio-economic and caste survey. And the intent is to cover any hospitalized treatment up to 5 lakh rupees of cover within a given year for a family that is covered. And if I say that what has been the overall growth in terms of or the importance that is placed within PMJY on oncology treatment, by far I can say that oncology has had perhaps one of the most rapid rises in the number of packages that have been introduced. So starting with a scheme that was initiated in 2018, when we had the first version of the health benefit package, which is labeled as HBP 1.0, there have been several revisions of the health benefit package, and now we are currently using a package which is the health benefit package that was announced in 2022. And what we see is that there has been a rise in the overall number of packages, which is more than about 5 times or close to about 5 times. So from about 112 total cancer treatments that were covered to about nearly 560 overall packages that are within surgical, medical, or radiation oncology specialties. And we also see that the rise in particular has been much more in terms of the medical oncology packages. But for some of the other packages like the radiation and the surgical oncology also, there has been quite a significant rise. So this is just to say that that there has been quite a steady focus on oncology treatment within the PMJY. But we also need to understand that is this scheme really effective in trying to lower the kind of financial toxicity that people face? So coming from the same study that I showed you earlier, where we reported estimates of financial toxicity, we also tried looking at that what is the extent to which patients were covered within any of the state-sponsored government-funded health insurance scheme or the centrally funded scheme, which is the PMJY. What is the extent to which there is a reduction in the expenditure in absolute terms, or reduction in the prevalence of catastrophic health expenditures and impoverishment? And what we find is that there is, after controlling for a range of other types of factors that may confound the overall cause-effect relationship, there is quite a significant reduction in the extent of hospitalization expenditure and the kind of financial hardship as a result of cancer treatment. It is not to say that the treatment is completely cashless, that the patients still incur expenditures, but it is to say that there is still a substantial reduction. And another important finding that came from the same study is that irrespective of the coverage of the health insurance, the expenditure that people incur in government hospitals is much lower as compared to private hospitals. So which means even after a coverage of the health insurance scheme, the expenditure in government hospitals is relatively lesser. But to say, and we were also hearing in the previous slide that there is something called time toxicity also, that there's a delay in the treatment also. We also tried looking at from the same database, that data that we had collected, that what has been the kind of trends in terms of timeliness of cancer treatment initiation in India in the past 3 decades, and has the introduction of these government-funded health insurance schemes, has it really sort of increased the trajectory or improved the timeliness of initiation of treatment by reducing some kinds of financial barriers to accessing treatment? And here on the graph that you see on the left side, you can see that it's not just all cancers that are reported, but different types of cancers groups are also shown. And this red line is the line that represents, which may be of interest to the group present here, which also includes the urogenital cancers. And the y-axis here.
Sir, can you please conclude the talk?
please.
Sure, I can. Sure, I'll try and do that. So basically, what I'm trying to say is that there has been a reduction in the timeliness of, there's been an improvement in timeliness of cancer treatment, and that the odds of initiation of timely cancer treatment has actually improved much more for those who are enrolled within the scheme. But as I said, that it is not to say that the cancer treatment is completely free of expenditure, even after having these schemes. There are other reasons that continue to be possible reasons for why there is still prevailing out-of-pocket expenditure. One is that there's a lot of diagnostic expenditure that patients have to incur even before the treatment is initiated. And the second is that there is a lot of balance billing. Hospitals continue to charge to the patients. And there are certain solutions that I've tried showing on the right side. I'll skip a few slides because of the time constraint. But just to say that there is also an onus on you all as clinicians to be able to perhaps impact on the cost of treatment. And that comes in the form of incorporating cost effectiveness evidence into the guidelines that you frame for standard treatment. So there is something called as health technology assessment, which generates evidence on cost effectiveness for formulating treatment guidelines. And there is now a very strong ecosystem of the institutions that have been established for generating evidence on cost effectiveness of newer therapies of treatment, etc., which functions closely with the government to be able to support such decisions on resource allocations. But what I encourage the clinical societies as yourself is to perhaps make best use of evidence on cost effectiveness for framing treatment guidelines. So again, I'll skip some of these slides, which basically show that in the context of urogenital cancers, that there is scope for incorporating such evidence. And this is my final slide, just to reiterate the same message. There is a high financial toxicity, and there are potential solutions to mitigate that. But beyond what the government can do, perhaps there is also an onus for clinical societies such as yourself to be able to incorporate evidence on cost. And happy to answer any questions if you have.
Committee for having me here. So what we do is
okay.
Right. So we need to, in the last
A decade. Today is the 9th year when immunotherapy was launched in India, 2016. And we're coming to that decade of using immunotherapy. And there's no doubt about it that the use of immuno has gone up tremendously in all cancers. We moved from advanced cancer, we moved to adjuvant settings, we have moved to new adjuvant settings. And we all believe why we're doing it is because of the tail of the curve. We are seeing our cure rates going up, and we are clearly seeing that happen so obviously that all of us believe in it very strongly. So that's why IO has made a place in cancer management. But the other statement which we make as medical oncologists is it has very less side effects. And we make this statement because we have lived through the era of chemo, and we said chemo was very toxic. And we kind of compare and say very less side effects. And I think that's where we start becoming complacent. And that's where the whole learning comes. I think we've seen this slide multiple times, this photograph. And what I can tell you in the last 9 years of giving a lot of immuno in a lot of cancers, I think I've seen every one of them, every type of toxicity. Luckily it happens to a few, but when it happens, it can be quite bad. We've seen if you use a single agent PD-1 inhibitor, you talk of toxicity in about 50 to 60% grade 1, grade 2.
But grade 3, 4 is only 10% or so. But when you add a CTLA4 inhibitor, your grade 3 toxicities do go up. So what are the general principles of management of IRAEs? Whenever you give immunotherapy to a patient, you need to counsel them. You need to talk to them extensively about what immunotherapy can do in terms of all those side effects which you saw in the diagram, how to look for them. And then you, as physicians, we need to catch it early and treat it. So we say, diagnose it first, grade the IRAE, rule out differential diagnosis, and do a workup of the patient for select the appropriate immunosuppression for therapeutic treatment which you're going to use. And then you do a quick reevaluation at 72 hours, and then you also reevaluate with time to see whether it's working or not. And use some guideline. Use either the ASCO guideline, the SITC guideline, the ESMO guideline, whichever you're familiar with. We use a lot of ESMO guidelines because they are nice and pictorial. If you read through the ASCO, the NCCN guidelines, there are a huge bunch of documents which are very, very difficult to go through. Basic is the same. You follow these principles as per CTCAE. If you're grade 1, your patients, you can just do symptomatic management. You don't need to stop the immune checkpoint inhibitor. You can continue the drug. If you're grade 2, hold the immune checkpoint inhibitor. That's the time we start adding steroids. And we can restart the ICI, provided your steroid dose comes to less than 10 mg per day of prednisolone. In grade 3s, we say that's where you stop the ICI, you get your subspecialties involved, you plan the steroids. You may have to go to higher dose of steroids, which can be methylprednisolone at 1 to 2 mg per kg. And then you need to taper them slowly over the next 4 to 6 weeks. And if symptoms don't improve in 72 hours or so, then you need to escalate care. There are rare patients of grade 3 that we do in re-challenge, though it can become a very controversial topic. And lastly, grade 4 patients, this is where you discontinue ICIs completely, except for the endocrinological toxicities. Here's where you're using the high-dose methylprednisolones, you're using infliximab, or you're going for MMF, you're adding tacrolimus, you're changing the immunosuppressants, and you're adding more drugs. And of course, some rare patients, you may have to do other modalities. Immune dose reduction, definitely not advised. We really don't do that. Even if we re-challenge the patient, we re-challenge the same dose, but you can always delay the duration of treatment. So let's quickly run through a few toxicities and just put in the little clinical cases. Hypothyroidism, the easy one, the common one. At least 30–40% of patients develop hypothyroidism when we give immunotherapy. Easy to do, we manage it. We look at TSH, TSH, and we do free T4s. We pick it early. We start patients on 1 mic per kg of thyroid replacement, but there are rare patients who may require very high doses. Other end of the spectrum, the difficult one, hypophysitis, a very, very tricky one. Here's where you get into a lot of trouble. If your patient suddenly comes in, you need to identify it, you need to catch it. It may be subtle change, some weakness, some fatigue, getting tiredness, and you need to pick it up. You need to do your 8 AM cortisol. You need to see, pick it up, do a TSH, do a ACTH, and then find out where you are sitting in. And this can be a problematic one in clinical practice. You have, the guidelines have clearly given you how to grade them and how to treat them according to the grade. So I'll quickly go through a patient here. This is a right cell renal cell carcinoma, 2012, had a right nephrectomy. In March 2021, he had recurrence disease. He had liver lesions, some lung lesions, and he had received treatment with IO plus axitinib for 2 cycles, and then he had progressive disease, and that's where he had come to us. We had started him on pembrolizumab, and this is August 2021, and he had very good response in 3 cycles. He developed balanitis. Now that's the toxicity I had not seen when I talked of skin dermatological toxicities. We used to say, yes, we have seen various kinds of skin toxicities. He developed balanitis, and it was very, very painful and miserable for him. But eventually it did subside after stopping, waiting, and then we restarted treatment. He completed 12 cycles in May 2022. PET CT showed almost complete response. There was hardly any disease seen. But in June, he had severe fatigue, difficulty in walking, not able to eat, and almost became bedridden. And that's where we saw his 8 AM cortisol was very low. And then he was diagnosed to have primary adrenal insufficiency, did all the hormones and found out actually he had developed hypophysitis. Started on steroids, responded immediately. Now the problem here is they're going to be on lifetime steroids, and hypophysitis is one condition where when we are tapering the steroids, they're immediately becoming bedridden again. And it was a very difficult problem. He travels and he ended up in another country in the airport, and he actually became flat on the airport. They had to, then he himself knew the toxicity, so he told them, give me a shot of hydrocod. And they gave him a shot of hydrocod, and he immediately became okay. And then now he keeps a hydrocod injection with him. He keeps the medical information, but that was a learning for us, for hypophysetis patients. Give them a card, give them instructions that if they end up in an emergency, that one shot of steroids can immediately make a remarkable improvement. We are having a tough time in him. He's in CR for the last 4 years, but his quality of life, he's got obesity due to steroids, and when we taper the steroids, he gets into trouble, and it's a very, very difficult toxicity. Pneumonitis, yes, we know this. We've seen this a lot. All of us are quite proficient in managing it. But just a quick word, there are different types of pneumonitis. You need to talk to your radiologist. They can be in different forms. It's just not that one pattern. So you can't say this pattern is pneumonitis alone. Your radiologist should be quite aware of these, and you and the pulmonologist should be aware of this to kind of manage it. Hepatitis, yes, we have seen this. This has its own grading and management. It's almost the same guidelines. Colitis, again, the same. What we learn is we need to make friends with every subspecialty, be it the gastro, be it the pulmonologist, be it the endocrinologist, and you need to know all of them, because when it happens, you need help from all of these teams to help you manage this patient. Arthritis, again, this is a toxicity we see, but this is one of the easy ones to manage. I like managing arthritis because this is one place where you can manage with 10 mg of prednisolone per day. This is one place where we say don't follow the routine guidelines of 0.5 mg per kg. You need a very tiny dose of steroid and they will immediately get better. And we had seen one of the earliest patients, this was RCC with lung secondaries. In May 2017, she had presented to us with multiple lung, peritoneal mets, bone mets, progressed on sunitinib, and we had given her nivolumab that time, and she had an extremely good response, but after a CR, she developed joint pains on treatment. And then she was diagnosed to have IRAs, got prednisolone at 10 mg per day, very low dose, tapering, on-off pain, but continues to be CR even now in 2025. That's 7 years down the line. So side effects may happen, but immune response can also last very long. One of the problematic side effects, encephalitis. This can be a real bothersome one. Luckily, it's a very rare one, but this is again something you can see in your patients. Here's our patient, RCC, May 2024, presented with headache and giddiness. He was diagnosed to have a cerebellar lesion, and then we operated the cerebellar lesion, and that turned out to be a metastatic RCC, and that was removed. He also had lung secondaries and adrenal secondaries. So we started him on pembrol and lenvatinib July 2024, got a good response, got 6 cycles, and then again came to us with giddiness, difficulty in walking, drowsiness. And the first thing we said is the tumor has relapsed in the brain. So immediately sent him for the MR. And the MR we saw there's actually no recurrent disease. There's a lot of white matter changes. And he was diagnosed to have encephalitis. Immediately got a CSF analysis. Everything came out negative except high proteins, ruled out all the other causes. And we needed to start him on IV methylprednisolone. But in 48 hours, we were not very convinced he's getting better, and that's why he immediately added on the IVIG. And one could have done plasmapheresis, but we gave him IVIG, and then we slowly tapered the steroid. He was in 1 month hospitalized, and then he slowly got better. He's completed now a few months down the line. He's back to walking, but he's off therapy, and luckily for us, he is in remission as of now in the PET CT scan. But encephalitis can be a very, very problematic side effect in our patients. Lastly, we moved to an adjuvant setting. I think all of us kind of say high-grade, high-stage tumors, operated RCC. We talk about using adjuvant immuno. Or even in bladder cancers, we are talking of adjuvant nivo. And that's one situation where what you talk to patients is completely different. When you were talking to stage 4 patients, they're fighting for their lives, and they are much more acceptable to accepting toxicity. And that's why when you talk about immuno, you're pushing the immuno there, and you say you're going to get a benefit, or you're going to hoping for that benefit, and you will have this toxicity, but we don't have any other option. We have to treat them. But when it comes to an adjuvant setting, here's the whole difference. Your patients, many of them are cured with that surgery. And do they really need that immuno? You are fighting for an added advantage, and that's where the counseling is very, very different. And I struggle with adjuvant immunotherapies. Whenever we talk about adjuvant immunos, our counseling sessions are much, much longer. We keep telling our patients, the side effects may be 10%, 15%, but I cannot predict them. And if they happen, they may be lifelong. And that's something that we say in adjuvant settings. Conversations with patients are very, very different. And in our minds, we need to be sure when we are offering adjuvant, what benefit are we offering it for, and what toxicity we may expect. This was one of our RCCs, September 2022, operated PT3N0M0 clear cell. He had a history of psoriasis, but he was not on any treatment. He had that long-term psoriasis. Psoriasis, we all debate as medical oncologists. Should we do it or not do it? In any other cancer, we say we will rather do it. If it's lung cancer, we'd absolutely do it. But in RCC, operated adjuvant T3N0, we debated a lot, but then we put the information in front of him. The patient asks, what is the best I can do to prevent a recurrence and what is the risk-benefit ratio? And you kind of explain that to him. And he said, okay, I'm ready to take the Pembro as adjuvant because that's when the data had come out. We gave him 6-7 cycles of Pembro and he had, that last slide. Okay. And he had a huge eruption of rashes and needed oral steroids and adjuvant had to be stopped. So that's why I think these are situations where we always have to be very careful. So my last slide. A very, very important team approach, monitoring diagnosis management, good baseline evaluation, assessment before every dose, early diagnosis, treat aggressively. I think patient education, but more important, physician education, and be in good terms with all your other teams of doctors, because that's where very, very important when you're managing RCC. And I kind of always say this, as a primary medical oncologist, if you're treating the patient, be in the lead. We have seen patients drift off from one department to another, and they get lost. And they eventually come back to you saying that you just gave the immuno, gave me this side effect, and you're not seeing them in follow-up. And we say always be in the lead, integrate all the departments together, and that way we can manage our IRAs better. Thank you very much.
Dr. Amit, one last question from my side. Do you ever re-challenge? Let's say somebody had a grade 2, comes down to grade 1. Do you re-challenge? What is your thoughts on that?
It depends on the patient I was treating for what setting. So if I'm kind of in adjuvant metastatic RCC, so if a patient is in complete remission, I am leaving them. If they had a very good response and their disease is quite okay, I wait and watch. But they have disease which is quite, I feel symptomatic, it's happened early, we have re-challenged patients.
Yeah, thank you. Just one question to both Amit and Ullas. So this is about the first statement that you made in the file, that when we counsel the patients that the immunotherapy is less toxic than chemo. After the talk, if you had to reframe that sentence, would you say that less toxic but not as toxic as chemo? Would you say less toxic but sometimes difficult? I mean, what should be the right counseling that we should be telling the patients, before they reach you?
That's essentially the most difficult problem and challenge. You want them to take it. You don't want to scare them off to not take it.
Yeah.
But we always tell them 10 to 15% patients can have toxicity. One, it is unpredictable. I can't choose the patient who's going to have it. And we need to watch for it. And we need to catch it early and treat it aggressively. That's the way we tell them. It can be unexpected. But luckily, it's only that small percentage. And PD-1 alone at least is less than 10%. So we kind of tell them that's the way it is.
So in one word, differently toxic. That's what I say. It's not the classical conventional toxicity. It's a different toxicity that you deal with. Different mindset. Like we say, specially abled people, it's a different toxicity. And that's what we say to them. Not less toxic at all. The more you use it, the more you realize that there's a special toxicity which will happen. And as he says, having been given so many of immunotherapies, we would have seen everything on that. Yeah. Thank you, Amit. Fantastic. So around 5 to 10%. So we always say 5 to 10% of people can develop. We cannot predict which 5 to 10% will get them. And then depends on the grade of toxicity on that. Thank you.
Thank you, chairpersons.
So maybe proceed for the second session, last session that is. May I invite the chairpersons, Sumit Goyal sir, is he there? Yeah. Jaskaran sir, Jaskaran Sethi sir. नहीं तो डेविड तुम आ जाओ आ जाओ गगन साइनी सर हैं आ जाओ आ जाओ सुमित सर you invite the speaker first. Anupam